Third, you need well-educated patients who understand their disease and can recognize the signs of a complication. So if you have congestive heart failure, you should be weighing yourself every day to see if you're retaining fluid. And if you wake up one morning and weigh 2 pounds more than you did the day before, you need to recognize that that's a problem. And finally, you need a system that you can navigate quickly. You need to pick up the phone and be able to get a hold of the right person right now to make sure they can help you stabilize yourself so you don't have a trip to the emergency room and an admission to the hospital. So we know how to do this. The problem is that our delivery system was designed to do something else and has not evolved to meet the changing disease burden that it's expected to deal with. First of all, we have what I like to call an acute care 19th century infectious disease model. That is episodic medical interventions of high intensity, treating a stroke, treating a heart attack, treating a broken bone. People don't generally seek medical attention unless they have some kind of acute problem to be addressed. Now, an acute care system makes sense for the kinds of things you'd see at a trauma center, and even for some non-life-threatening acute conditions like a bladder infection or a sore throat. The problem is it's become a one-size-fits-all delivery system in the face of very different delivery challenges, the most significant of which is chronic conditions. Secondly, doctors really aren't very good team players. Most doctors still practice by themselves or in small groups. I think it's less than 4% of doctors are in group practices of more than 50. They act as autonomous, isolated economic entities without a lot of formal communication or collaboration with one another. And that creates a real problem because the individual with one chronic illness is being treated by 7 to 8 physicians. And if they don't communicate with one another, then the potential for drug interactions and gaps in care and complications is just enormous. And this doesn't just happen to physicians who aren't working together. There's a group of gastroenterologists in Oregon, 15 doctors, who have been in the same practice under the same roof for 20 years, discovered recently that the rate of upper endoscopy for esophageal reflux disease varied 400% with the 15 doctors in that practice. They weren't talking to one another. So that's the second problem. The third problem is we don't really have very good data, at least not 21st century data. Most information is still written down on paper charts that are locked away in doctors' offices and hospitals throughout the country. It's not in a form that can be computerized and shared and aggregated and tracked. And even if you have an electronic medical record in your office, it may not be interoperable with the 6 or 7 other doctors who are taking care of the same patient, let alone with the dietitian and various other caregivers who are involved in the management of chronic conditions. So these structural problems, they aren't anybody's fault. They're just that the delivery system went this way and what was demanded went this way. And these structural reasons are why most people with chronic illness still interface the medical system only when in crisis and get the scientifically appropriate care only about half the time. Finally, there are a set of perverse incentives that actually reward isolated acute care interventions at the expense of prevention and wellness and the appropriate management of chronic disease. Dr. George Halverson is the current president and CEO of Kaiser Permanente, and he wrote a book a few years ago called Healthcare Reform Now. And in it, he points out that there are 9,000 individual billing codes through which doctors and hospitals get paid, but there's no code for a cure. Hello? There's no billing code for prevention. There's no billing code for health improvement. They're not billable events. And the result is a system that looks exactly like you'd expect a system that has those kinds of incentives. Most of the money is invested in revenue streams based on acute care interventions. Every hospital in America has got a cardiac wing. Most of them have an imaging center. Often they have a cancer center because we pay really well for those things. I don't know a hospital in the country that actually has a wing dedicated to mental health and chemical dependency. That's kind of a lost leader in our medical system, but would probably have a huge impact on population health. So my point is that this system itself, the way it's structurally designed, does not have the capacity to achieve the triple aim, no matter how much money we throw at it and no matter how we pay for it. So this debate over a public option or a single payer system or an employer mandate or an individual mandate is simply about how to pay for something. And the paradigm shift is we've got to ask ourselves what we're buying. We have to fix the system, or else we're going to continue to have dramatic cost increases. Albert Einstein once said that you shouldn't use an old map to explore a new world. He's absolutely right. Every new generation faces a new world and a new set of challenges that can't be solved by clinging to the past, but only by developing a new set of tools with which to solve the problems that we face today. So let me take just a moment and talk about how I see this playing out around the country and here in the Pacific Northwest. There's nothing in the legislation that's going to have a significant impact on the current behavior of the system or the current behavior of individuals, except to give more people a way to access a system. So cost is going to continue to dramatically escalate. A lot of these people are going to end up in the emergency room because we don't have the primary care capacity to absorb them. And then next January, the first of 78 million baby boomers are going to become eligible for the Medicare program. And in states like Oregon and Washington that have very, very low Medicare reimbursement rates, doctors are going to stop seeing people when they turn 65. I don't know about Washington, but in Oregon, more than half the physicians have closed their medical practices to Medicare patients, and some of them are actually dropping people when they turn 65. So you're going to have a whole group of older people who have chronic illnesses, who have coverage under Medicare, who can't find access to a primary care doc and are going to end up in the emergency room. And the national debt's going to start going through the roof, $12 to $70 trillion, creating enormous pressure on the United States Congress to do something. Now, health care is ultimately a local transaction between a provider and an individual in a community, and it's at the community level where this crisis is rapidly going to become unmanageable. So my point is that notwithstanding how historic this healthcare legislation was, unless we bring about fundamental change in the delivery system, our future is fraught with jeopardy. Now, let's ask ourselves for a moment why it is so hard to get our arms around a system that everybody recognizes is broken. Now, I can probably do that best by drawing in another analogy between the U.S. healthcare system, or the need to change it, and the way successful businesses or organizations evolve. So let's take a business. Businesses generally grow by taking advantage of an investment climate that allows their business to grow and flourish. And as the business grows, usually the business environment in which it operates begins to change. And if the business doesn't change its business plan to reflect the new circumstances rather than the old, growth flattens out and then begins to fall off. General Motors is a classic example of a company that didn't do that. They continued to build big gas-guzzling cars in the face of high oil prices and concern over global climate change, and paid their employees in part by promising them rich pensions that they didn't fund. Now, most successful businesses, when they recognize that the world's beginning to change their business model and create a new growth curve based on the new set of circumstances, not the old. But for a while, the old business model and the new business model have to coexist. And the area between those two curves has been called the area of paradox. And it's an area of great anxiety and uncertainty. People know the world's changing, they know what they're doing doesn't work, but they don't know what the future holds. And so the tendency is to hold on to the old system, even though it's taking us over the falls. I would suggest to you that this area of paradox is where we find ourselves in the United States and in Oregon and in Washington, not just with medical care, but with public education, with energy policy, with transportation policy, as well as health care. And in order to move to the new growth curve, you've got to let go of the old one. I don't know if any of you have been in outdoor school, but there's a game called the rope game, where they put you on a post about 10 feet off the ground and you got a rope. And over next to you is another post 10 feet off the ground and another rope, and you're supposed to move from one post to the other. That post is just far enough away that the only way you can get there is for a minute you got to let go of one rope and grab the other. What we're lacking today is a vision of what that new growth curve looks like. Being able to describe what the new model is prerequisite for getting people to actually go there. And the opportunity for us here in Oregon and in Washington and in other smaller innovative states